Hi there, everyone. My name is Kristen Foskett, and I'm going to be presenting to you today sexually transmitted infections screenings and updates. So a little bit about me. I'm a family nurse practitioner. I work in the Dalles, Oregon. I'm also a sexual assault nurse examiner for adults and adolescents, and I've been doing that work for about 6 years now. I also work as an instructor with the Sexual Assault Task Force. So we have a few objectives today. The first is going to be just listing the most common sexually transmitted bacterias and viruses. What are the highest risk populations for those infections? We need to understand the modes of transmission, as well as recognize the symptoms and the symptoms of each of those infections. And then finally, how do we test and treat each of these infections? We're also going to talk a little bit about prevention as well. Now I'm going to try to tie this in as much as I can to our work as sexual assault nurse examiners. Some of the details might be probably a little bit heavy or a little bit deeper than we may need to know, but I figure more information the better, kind of absorb what you need from it, and you can always revisit this later. So I list here some of the most common infections that we're going to see or our patients are going to have questions about. So we're going to go over all of these today. And the first being chlamydia, which is the most common bacteria that we're going to see in the clinical setting. Now, we see about over 1 million people infected with this annually. Women are significantly higher rates than men, and a lot of that has to do with just anatomy and physiology. You'll see here on the chart that, there's a significantly higher rates of women than men here. Now, of women, we're going to, ages 15 to 19 have the highest incidence of infection. And we're also seeing just an increase in men who have sex with men, increase in chlamydia as well. So, that does warrant one of the reasons why we treat prophylactically for chlamydia often at the time of a sexual assault. Any time is fine to treat afterwards, especially if a patient might have some concerns about it. It's always an option for them. So you probably have a little bit of experience with that. So we know that chlamydia is transmitted both vaginal, oral, and through anal sex. So we can get infections in all of those areas. Oftentimes we only think about, sorry, and I meant to write genital there, so it's not just vaginal. You can get infection for males as well. So for the genital and rectal infections, the majority of people are actually asymptomatic. Of those people who do show signs of infection, for women, they're going to have some vaginal discharge, typically, kind of a more copious discharge, kind of thicker and a lot more liquid than normal for that person. They might have some bleeding after sex or have painful sex. Some of that bleeding is caused from what we call cervical friability, which means the tissue on the cervix, it bleeds very easily. Just with even a little touch of the swab, you might notice that there's some bleeding with that. And then both men and women have some pain with urination. And men will also have penile discharge, usually a little bit more like clear discharge. So for rectal infections, kind of generic symptoms of pain, discharge, and bleeding. Of course, any discharge with a rectal infection would be concerning, but that bleeding and pain can be suspicious for plenty of things. So assessing risk there. And then pharyngeal infections, just a sore throat, nothing really else. So it again is not very specific. The biggest concern here is that a lot of these people are asymptomatic, and for women especially, if they're untreated, it can result in pelvic inflammatory disease, which can in turn lead to infertility and higher risks of ectopic pregnancies. For males, you might see an epididymitis, and in some circumstances, something called Reiter's syndrome, which is three things. It's a reactive arthritis with a conjunctivitis and the dysuria. So they seem to happen together, and that's called Reiter's syndrome. And then there are other types of chlamydia. There's plenty of strains of chlamydia, and those strains can cause ocular and respiratory infections as well. So for the ocular infection, the conjunctivitis with the discharge from the eyes, it's actually one of the world's leading causes of blindness. I was surprised to find out. And the respiratory infections can just look a lot like pneumonia. So there's plenty of other strains. And here's some lovely pictures. So I'll be showing you a picture of the gonorrhea discharge in a minute, but this is something, you'll notice that this one, it's like kind of a milky discharge, but anytime there's penile discharge, you want to test for sexually transmitted infections. And here's the conjunctivitis here. Okay, so who should be tested or screened, I think would be a better word, because oftentimes people are asymptomatic. So offering screening tests and recognizing who those high-risk groups are is really important. First of all, sexually active, non-pregnant women under the age of 24. And by the way, this goes for gonorrhea as well. So if you remember these things, it's for gonorrhea too. We usually test at the same time for both of those infections. Anytime a patient has a new sexual partner, it's always a good idea to get tested. All pregnant women are going to be tested for chlamydia. And high-risk men should be tested for rectal chlamydia. That is a recommendation only from the CDC. The USPSTF recommendations I didn't see any mention of that yet for them, but it's definitely something to offer. So when we do testing, the most sensitive testing is the nucleic acid amplification test. So the APDMA test or NAT, N-A-A-T. And that can be done in a couple different ways. The first and easiest way to do it, which you will likely see quite frequently, is just a dirty catch urine. First void urine is ideal. It's going to have the most bacteria in it. If it's not first catch, within it has to have been more than an hour since they've urinated. Otherwise, you're going to want to wait or do a swab test. But urine is really super easy. So if they did a clean catch urine for a UA, remember you can't use that. You need a dirty catch. So when you're doing swabs, there's a couple ways you can do it. For women, it's really easy. The research actually shows that women can self-collect their own swabs. That's really nice and convenient for them, and the studies show that they might actually collect better swabs than the clinicians. So definitely an option. Same with rectal swabs; they can self-collect if they want. Urethral swabs are super uncomfortable, so typically males would opt for a urine test if given the option. All right. There is an option to do culture testing. We don't have that in our clinic. It's less sensitive, takes longer. So that's out there. And then there's some mail-in kits that are out there nowadays that are, if patients want to test at home, that is out there. Okay. So a person tests positive, and the first thing we want to do is treat the patient. We also want to treat any of their possible partners and remind them to alert their partners. So that's really important to stop the transmission. It is a reportable infection, and at the end I will give you a link to a whole list of other reportable infections, but it's our duty to report that if somebody shows up positive. So you have two options for treatment. Most frequently, you're going to see azithromycin, and we usually just give 1 gram one time. And it usually comes in 250 milligram or 500 milligram pills. So it's a really easy treatment. The other option would be if they have an allergy, we can go ahead and use doxycycline. The downside to this is that you have to take it twice a day for 7 days. So anytime you add in more days, more times a day, there's going to be issues with just people going, following through with that. And so easier the better, I say. But you guys who are using this as prophylactic treatment in the emergency room setting or clinic setting after a sexual assault, you're pretty much always going to see that azithromycin 1 gram one time as a prevention. Okay, so gonorrhea seems to come in pairs with chlamydia. We talk about the two together. So oftentimes with testing, you're even going to see it'll just say like CTGC or GCCT. Those are the the names of the two tests together. So we see gonorrhea a little less frequently. The chlamydia, if you recall, was over 1 million cases a year, and there's about 700,000 a year of gonorrhea. It is the second most common, and same groups of people are higher risk. So women between that ages of 15 to 19 and incarcerated women. We are seeing a lot more gonorrhea against men who have sex with men as well, and oral and anal gonorrhea as well. And transmitted the same way as chlamydia. Again, it may not be symptomatic at all. I was interested to find that about 95% of women have no symptoms. And if they do have symptoms, you're going to see a very mucopurulent discharge, vaginal discharge. So babies can also get this infection, and if that's the case, it'll be a very thick mucopurulent eye discharge, which gets worse over time. Starts out as kind of a little conjunctivitis. For men, if they are symptomatic, they will have some discharge. It'll be a little bit more mucopurulent than the chlamydia, and they'll have some pain with urination or ejaculation. And again, if left untreated, can lead to pelvic inflammatory disease, ectopic pregnancy, epididymitis, and with gonorrhea can lead to skin infections and get a rash. So here's some lovely pictures. But I wanted to show you this picture of the cervix because I thought that this was a good example of a friable cervix. So you see here, they have a gonorrhea infection. There's quite a bit of mucopurulent discharge. And see this just so red, and just if you touch that with a swab, it would just start bleeding. So that's what we really talk about when we talk about friable cervix. A little bit more of a purulent discharge here in the penis and that poor baby's eyes. And the sore throat, I mean, that looks like it could be an upper respiratory infection. It's really nonspecific. All right, so testing is exactly the same with chlamydia. There is nothing different. The only thing that I found that was any different was the CDC, discussing the oral screening and rectal screening for men who have sex with men. And it's such an easy swab to do that it's, why not? All right. So when we're testing or when we are treating for gonorrhea, we need to treat with two agents, and that's because there is a ton of resistance in gonorrhea. I'm sure you guys have read about kind of these new strains of gonorrhea that are super, super resistant, that may not have treatment, and kind of that's the road we're headed down, is maybe a non-treatable gonorrhea in the future. So do not use fluoroquinolones. They will not work against gonorrhea. There's a really high level of resistance at this point. So what we're trying to do here is treat both with azithromycin or doxycycline and with a ceftriaxone injection. We're going to do 250 milligrams IM, and I am sure your patients have told you if you've given this before, it really burns. But we need to do both of those, both to treat a known infection as well as to treat prophylactically after a sexual assault, or if somebody knows that they had sex with somebody who is infected. Again, this is a reportable infection. The one last thing to mention is that if they have a severe anaphylactic penicillin allergy, you can use doxycycline alone. And if there's any confusion about that, you can, call infectious disease. That will be helpful. All right, so let's talk about a protozoa parasite, Trichomonas. As you see here, this little guy, he's got these flagella hanging off. So when you see this under a microscope, these Trichomonas are actually moving along, and it depends how active, how good you are at doing the microscopic exams, but you could just see them kind of floating along. So super common, about 2.3 million people, women ages 14 to 49 are going to have this infection. So quite a bit. Large majority, again, are not going to be symptomatic. There is still a possibility, about 1% chance that, or 1% of the population who has not had any sexual intercourse can still be affected by this infection. So we see women who have sex with women get infected with this, as well as women who have sex with men. So everyone's at risk. African American women are significantly higher risk group, or higher rates. So as I mentioned, it can be any kind of sexual contact with the genitals, not always just insertive sex. When men have symptoms, if any symptoms at all, it's going to be just an itching or irritation, burning, maybe some discomfort with ejaculation, and maybe some discharge. For women, the symptoms really vary. I would say for the most part, a more copious, the discharge, I see more that yellow-greenish, but it can be clear or white, and it usually has a pretty fishy smell. Can easily be mistaken for a bacterial vaginosis. And then I wanted to put this picture up because you might have heard of the term strawberry cervix, and that is specific to Trichomonas infection, and this is what it looks like. It's if you ever see this, that would be give you a real reason to go ahead and screen that or test that person for Trichomonas. But yeah, that's pretty classic. So there's lots of testing to do when it comes to Trichomonas. The cheapest and most easily accessible that you could do in any location, as long as you have a microscope, is the wet mount. But you really need special training to do a wet mount. And even those of us who have training that aren't doing it every single day, you might not either get a good enough sample, you might not know what you're looking for, and you might not pick up the Trichomonas. One thing that does make your likelihood of not seeing that infection is, say you take your swab, you put it in your little tube, but then you stand there and talk to the patient for a few minutes. As the temperature changes and it's kind of out of the vaginal environment, the Trichomonas can actually die. And if they're not moving around, they're really hard to pick out in a microscopic exam. So that brings down the sensitivity of the exam. As you can tell, it's got the lowest sensitivity. I do see, for the most part, a lot of people using the Affirm test down here. I was actually really surprised to find out what low sensitivity that has, actually. But it is really super easy. The downside is it's very expensive, so not a very good option for people without insurance. Now, we don't have the Aptima test where I practice, but this would be a really great option. If you see here, if you have the Aptima Trichomonas test, you've got great sensitivity and specificity. So that might be your go-to if you have the option. So we treat typically, we treat prophylactically typically after a sexual assault. So many of you who've been practicing recognize this medication, and when we're treating for that trichomonas. So you want to go ahead and give them 2 grams one time if they're in the hospital setting. If they're not in the hospital setting, you kind of have the option. You could do the 2 grams one time, or you could do 500 milligrams twice a day for 7 days. The 2 grams one time, that really can cause a lot of nausea and make people not feel so hot. So given the option, a lot of people would rather just kind of take it over 7 days. They do need to avoid alcohol. So if you are giving it as a prophylactic treatment after a sexual assault, you really, you've probably already talked to the survivor, and you know if she or he has come in contact with or had it when their last alcohol drink was. So kind of consider that. If it was in the last, 12 hours or so, you probably want to avoid treating them and maybe just send them home with a prescription. That's certainly an option too. And advise them to avoid alcohol while using the medication, and for up to 72 hours after the medication. It can give you a disulfiram-like reaction, so they'll feel really crummy and sick after using the alcohol mixed with this medication. I was interested to find that there is a resistance to metronidazole or FLAGYL, and in those cases of resistance, you can use tinidazole. And it might also be worth your time to educate anyone who's been treated prophylactically or anyone who you're not going to see again that there is some resistance. And so if they do have any symptoms pop up, to follow up with their primary care or local health center for follow-up testing at 2 weeks, as we recommend. Okay, so moving on to syphilis. So syphilis is a bacteria, and it's been around for ages. Many of us have heard about it. Maybe not everybody has seen it or come in contact with it, but it is really coming back. And it's the rates are actually the highest that they've been in about 20 years. So, and that includes for congenital syphilis. So I put this little map here at the bottom so you could kind of see where Oregon's at, but we're right on the border of California, and some of you guys listening to these slides might actually live right on the border. So if that's the case, you really want to think about your risks there and consider that. We don't treat prophylactically in cases of sexual assault for syphilis, but educating everyone, our patients, and just providing that information could be super helpful for them so they know what to look for. We're seeing the highest rates actually down in Louisiana and New Orleans. There's a huge resurgence in that area right now. So the highest risk people are men who have sex with men. If you look here, that's really the large majority of the infections. Okay. So you can transmit syphilis by any direct contact with a sore during vaginal, anal, or oral sex. And it can be transmitted congenitally to the baby while the mother's pregnant. There's 3 stages of syphilis. I'm sure you guys all kind of remember this. We're going to probably see the primary or secondary symptoms first. I doubt we're going to be the ones to pick up on any tertiary symptoms, and hopefully they've been treated by that point. A primary symptom is going to be a painless genital ulcer. So a picture of kind of what's going on in the penis here. It can also occur in the oral area or anal area. And as you can imagine, if you maybe given your certain circumstances, but if you had a painless anal ulcer, you may not notice it, or certain of our folks may not notice it, and that's high time to kind of transmit it to new partners, especially in unprotected, not using condoms. So after you get your ulcer, it heals up, it goes away, some time passes, you'll get your secondary symptoms, which are going to be macular or papular rash. This can occur on the trunk and extremities. I've also seen a papular rash on the palms and feet, bases of the feet, and it will come along with swollen lymph nodes and a fever. So that's a good opportunity to just do screenings for syphilis. And then finally, the third stage is the tertiary stage, and that's when the spirochete bacteria has kind of weaseled its way into the central nervous system, and it's creating changes in the neurons. And we're going to see like kind of a chronic inflammation around the meninges, and so it'll be a kind of a meningoencephalitis, as well as there's a slow degeneration of the nerves in the spinal column. And when that happens, people will experience kind of this feeling of, like swaying, not knowing upright. So a little issue with that. There can be confusion, there can be some neuropathy. And again, that's probably not something that we're going to be picking up on, but interesting to know about. So who do we screen? So screening asymptomatic patients. We're going to test every pregnant woman. We need to screen at least annually men who have sex with men, people who are already infected with another STD or sexually transmitted infection, as well as people who have HIV. And then our highest risk folks, those who will exchange sex for drugs or money, have multiple partners without condoms, and anyone recent incarceration or as a sex worker. So all of those people they just get screening tests. And then anyone who has any kind of symptoms, so genital, anal, or oral ulcer, rashes that are kind of have some systemic symptoms, like I said, with the lymph node swelling and the fevers, and then getting into some neurologic symptoms that don't seem to link up to a disease process that's going on for that person. Now, for these folks, testing is super confusing. I put this algorithm on here not because I want you to memorize it, but mainly just because it just goes to show that it's super complicated. So we usually start by screening with something called an RPR test. It's the Rapid Plasma Reagent Test. And that is a non-treponemal, meaning it's not testing for antibodies directly to the syphilis bacteria. It's a great screening tool. It gives us a titer, meaning it's either completely not reactive at all, or there is some reaction, so a 1 to 500 ratio or a 1 to 3 ratio. Now, if it's positive and we've got a ratio going there, that's going to tell us, okay, we need to do a treponemal test. And that treponemal test is looking at antibodies that a cell is releasing in response to a spirochete bacteria. Maybe not specifically syphilis, but there's not a whole lot of other ones that we should be seeing in the human body. So that's a big, that's going to be kind of our confirmation test. So if that's positive, then we want to go ahead and treat that person. If we did our non-treponemal test, so for instance our RPR test, and that shows a low ratio, and we reflex it and do the treponemal test, and that's negative, that person has either been previously treated for syphilis and still has some other, something to make it reactive, or they're just reacting through the RPR test, but they don't have an active infection. And I think the biggest kind of challenge for clinicians who don't see this a lot is that, oh my gosh, the RPR test is positive and you just want to rush to treatment. And that would be a little bit too quick. So using this algorithm, they tell you pretty much everything to do. For the majority of us who working just as SANE nurses on, we are working with a team. And so we're never going to be kind of looking at these results and making the decision on what to do. But I think it's really just important to understand how it works and what we're looking for. And there's a whole bunch of tests here, these treponemal tests that you can see. Okay, so moving on. So now we know a patient has tested positive for syphilis. Their treponemal test is positive. They have a high RPR, and we're going to go ahead and treat them. Depending on what their symptoms were, if they have primary, secondary, or early latent phase syphilis, which is the majority of people, they're going to get 1 IM injection, 1 time of penicillin. So really super straightforward and easy to treat. And of course, this is reportable. So these folks, you're probably going to want to test them again, in like kind of a retest to see if they've been reinfected. Keep in mind their RPR test is probably going to show up positive because they have been recently treated. And that can maintain a positive result for quite some time, 3 to 6 months. And if a person has HIV or is immunocompromised, they're going to continue to maybe show a low titer RPR test ongoing for quite some time. Again, just little pieces of information. It may not be super helpful to your daily work. Okay, so HIV virus, this is something that we need to know a little bit more about, mainly because we're often treating survivors of sexual assault prophylactically for the HIV virus. And just a reminder, HIV is a retrovirus, so it's an RNA virus that goes into those cells, the CD4 cells, which are our immune system cells, and they insert a DNA copy of their genome into the host cell. And that allows them to that virus to replicate inside of those CD4 cells. So let's look at the risks and who is the highest risk here, the highest incident. So we see Black men who have sex with other men is the highest incident in the United States. And overall, men who have sex with men is the highest. And we'll talk a little bit about why. There is about 1.1 million people living in the U.S. with HIV, and unfortunately 1 in 7 of them didn't know they were infected. So it's really important to be screening everybody. The great news is rates are going down significantly, and that is really reassuring and super positive. Okay, so after a sexual assault, it's really important that we know kind of the risk in the area that we live in. So in Oregon here, we're a little bit lower risk, 1 in 214 people. Now you can actually go onto your county's website, Department of Health, and you can get a little bit more specific information about your county so that you'll understand. The South down here is pretty dang high, and there's probably, there's a lot of reasons why that is. So transmission during sexual assaults, I really wanted to focus on this because you could do a whole presentation just on HIV alone. When we are working with a survivor of sexual assault, we need to assess kind of their risks there. And a lot of people have paperwork that they fill out, kind of a checklist that allows for them to assess that risk. But I listed some things here that would increase the risk of transmission. So any male-on-male sexual assault depends on the region where you're in. Is there a high prevalence of HIV in that region? Were there multiple assailants? That kind of comes into possibility of injury, which could increase transmission. Was there any anal sexual assault? So we know that the anal mucosa is thin. It's easily torn. Hence why men who have sex with men, there's often higher transmission rates than through vaginal sex. There's also less natural lubrication in that area. So both of those reasons would increase the risk of transmission. And in any sexual assault, there's a lot less natural lubrication, and that can increase the risk of tears and mucosal tears. So we're looking for that trauma, bleeding, or genital lesions, and that includes herpes lesions, syphilis lesions, anything like that, as well as, a very friable cervix could even something to think about. Did the assailant, is that person an IV drug user? Was the patient infected with any other STDs? As I mentioned, herpes, chlamydia, that can all increase transmission of HIV. And is there any sex work history, or have they paid someone for sex in the past? So here's your rates of transmission. They're actually pretty low. Vaginal, pretty significantly lower. And oral sex is very, very low. So if you're concerned about kind of making a clinical judgment on risk, always feel free. There's a bunch of resources for you out there. At the very end of the slides, I'm going to go ahead and list everything here, so you don't need to write this down right now, but OHSU is a fantastic resource. It's 24/7. You can call the infectious disease clinician on call and do a risk assessment. And for any adolescent or pediatric cases, you always want to consult with the pediatric infectious disease specialists. And then if it's from 6 a.m. to 11 a.m. or 11 p.m., you've got the option to call this national line as well. So I really love this chart. I think it's really helpful to see kind of what's going on with the virus and the cells, and over time. So what you'll notice here is we get this huge peak, and that's a peak in the HIV copy, so the viral load essentially. And you see that it spikes right here between like 3 and 9 weeks. Now in the past, we often weren't even getting a pretty good test till 6 to 12 weeks. So this time period where people often have no idea that they're infected have the highest viral loads. So this is the highest risk time to be transmitting it to other people. They don't know they're infected, and they've just got tons of virus in their blood. So that's pretty dangerous time. This is also a period of time that you're going to have any first symptoms that are just going to last for, it won't last long. It could last 2 to 4 weeks max. But you'll get kind of symptoms of like a fever, rash, malaise, kind of just overall not feeling good, kind of flu-like symptoms, or you might not have any symptoms at all. But those symptoms are going to go away. Somebody's going to think, oh, I just had the flu or whatever, and that'll just be going on for years. Most people's viral load stays pretty dang low for many, many years, and then it's going to spike up. And when it spikes up here near the end of the disease process, you'll see that the CD4 lymphocyte cells are really plummeting, and that's when you're seeing these kind of other symptoms related to a low immune system. So rashes, infections, fungal infections that normally wouldn't be present in a healthy person, just a lot of things related to a low immune system. So yeah, there's two stages. Again, there's that acute retroviral syndrome at the beginning after the initial infection, 1 to 4 weeks after transmission, and then at the very end of the disease process when the lymphocytes levels are real low. So the testing I want to talk to you about, in the past we were using just an antibody test, looking for antibodies in the blood. And the third generation test was just, you'll see here, this was what we were using for a very long time. And we start to be able to test at about 21 days, but it's usually 6 weeks after the infection is when it's most reliable. So 6 weeks, 3 months, and 6 months is usually when we'd always done the testing. Now, if you think about it, when we look back at that chart we just looked at, we were seeing that huge spike, a little bit before this. So people could transmit the infection before they knew they had it. Well, now we have the 4th generation HIV test, and the great thing about this test is it uses 2 types of technology. So it looks for both antibodies using the ELISA test, but it also looks for something called the P24 antigen. And that measures the core protein, one of the core proteins in the HIV virus. And that is detectable usually between 2 weeks and 8 weeks. Typically around 4 weeks is a great time to do that testing. And of course, we'd retest again if there was risk, but 4 weeks we can get a positive test at that point. So that can also decrease transmission when people know that they are infected. The one thing to know about the P24 antigen is that it does decrease at about, the sensitivity falls at about 8 weeks. So after that point, we might want to, it'll still be testing for the antibodies from the ELISA test, but you don't want to just be testing for the P24 antigen. I don't think that's really available alone at a lot of places anyway. And then there are like rapid oral testing and whatnot. You definitely always want to follow up with serologic testing after doing that. So for treatment, the first thing I wanted to talk to you about is pre-exposure prophylaxis, because you're going to see this in a lot of areas nowadays for people who are higher risk for the HIV infection. So serodiscordant couples, meaning one person is infected with HIV and the other person is not, and they are having regular sex. The person who is not infected would be using a daily medication called Truvada, and that is super, super, super effective and really fantastic in helping prevent that person from getting HIV. We also see it in groups like men who have sex with men, who have multiple partners, who are having high-risk sexual behavior. So you'll definitely see in certain areas people are choosing to use this medication. And it's just 1 pill of Truvada daily. And we do some basic labs to kind of monitor it. So, but what we're probably going to be using the most is the post-exposure prophylaxis. And that's called PEP. And that ideally is started within 4 hours of possible contact, but it can be used up to 72 hours. If you're confused about that, just call the infectious disease line. And that is a combination of 2 medications. The Truvada pill is actually 2 medications in one. You're going to take 1 pill daily for 28 days. And then you're also going to take the Icentris, which is one type of medication. You'll take 2 pills a day for 28 days. It's very important that they take it for the full 28 days because it's not effective if you stop halfway through. So you have to take the full amount, and the patient needs to be counseled in that. This medication is okay in pregnancy. It is fairly well tolerated, but it does cause some nausea. There's rare cases of Stevens-Johnson's syndrome. And mainly we're just going to be monitoring the renal and liver function of the patients because there can be some, especially if the patient already has some kidney disease and whatnot. So I usually recommend people don't drink alcohol either to avoid any kind of liver dysfunction. So how are we going to pay for this is a real challenge. OHP does not cover this medication or both of these medications. OHP Plus does, so you can always check with insurance and find out what kind of insurance they have. If they have private insurance, they're going to have a copay, so we want to find out how much that's going to be. So it's our responsibility to kind of take down the barriers up front for people to have access to this, and both of these medication companies have payment assistance programs for folks. So even if they have insurance and they just have a really high copay, or they're unable to pay for what they're responsible for, they can fill out the paperwork, which we do with them in the hospital setting when we're with them, and we send that all in for them. They'll get a voucher number that they will put onto their prescription and can take to the pharmacy with them. So the biggest thing is we want to take away a couple barriers. The first barrier is getting that medication as soon as possible. So making sure that the setting that you work in has that medication available, or that you're sure that the pharmacy nearby has one. Has that medication, because like I said, within 4 hours is really the best. The other barrier is cost. So the payment assistance program is there, and it's just our responsibility to go ahead and fill out that paperwork. It's kind of arduous, but it is so worth it if it prevents even one case of HIV. And then we want our patients to follow up within 5 days with their primary care provider. Oftentimes, depending on the prescriber, they may only prescribe like 5 days. I always remind the prescriber it can take like 2 weeks to get in with a primary care doctor. So if they don't have an appointment already set up, that can be a challenge for sure. And so it does take away a barrier if we can give them that full month of their medication. We want to repeat, before we even give the medication, we need to be doing some baseline lab work. And we need to make sure they don't already have HIV. We need to make sure they don't have a hepatitis infection, hepatitis B specifically. And we want to check out their renal and kidney function, baseline function. And then we want to repeat those labs again at 2 and 4 weeks. So they should be following up with their primary care provider as soon as they can, repeating their labs, and then they need to repeat their HIV antibody testing. So that 4th generation test, they'll do it at 6 weeks, 3 months, and 6 months to confirm that they do not have, they did not contract HIV. And if somebody shows up positive, again, it's reportable. Sorry, I know this is a lot of information, but I do have some papers at the end for you guys. All right, so getting into the HPV virus. So this virus, I would say I get the most kind of concerned folks wanting to discuss. There's a lot of misunderstanding about the HPV virus, and so the more information, the better that we have. So there's over 40 types of the HPV virus that affect the anogenital area, and over 100 types that can cause warts. So it's super duper common. The kind that we care about most is the strains of the virus that can cause cervical, anal, head and neck cancers, vulvar cancers, and penile cancers. Warts are super annoying, and nobody wants to have genital wart, but they're not gonna like cause cancer. What we do care about is these strains that cause cancer. So 50% of new infections are between the ages of 15 and 24 years old. And there's 14 million new HPV infections annually. So about 80 to 90% of us are going to have HPV at some point. Luckily, most of us with a healthy immune system will clear that. But for those high-risk strains and for people with a low immune system or immunocompromised, there's about 12,500 plus cases of cervical cancer every year. So I put over here this is a little something about the vaccine and what's covered under the vaccine, but there's 13 high-risk strains of the virus that can cause cancer, and the newer vaccine covers 9 of those strains, 7 of the strains. And then there's the low-risk strains, and those low-risk strains, there's, like I said, gosh, almost 30 of them can cause warts. Number 6 and number 11 are the most common to cause warts. Those are the genotypes of those, and luckily covered with the vaccine. So wanted to put some pictures of the warts on here, as well as changes to the cervix, which would be caused from the higher risk strains. Again, the warts are annoying, but in most cases not causing as much concern as the high risk strains. And it's transmitted skin to skin or through sexual contact. Oftentimes, there's so many strains of it, there's going to be no symptoms at all. People might have genital or anal warts. There could be oral growths or oral warts. And what we do get concerned about is those changes to the cervical cells, oftentimes with no symptoms at all, or something that changes that you might need to see during a special procedure like a colposcopy procedure. And then possibly with a higher grade changes on the cervix over time with the HPV virus, you might see some cervical lesions. Okay. Oops, I got ahead of myself there. Oh, well, let me go backwards. I was just talking a little bit on the previous slide, which it won't let me go back to, about testing. So testing is for ages of women under the age of 30. We're only going to be testing every 3 years for the Pap test, and that's just checking for abnormal cervical cells. So we start screening at age 21, and up until age 30, we're just doing the Pap screening test. We're not outrightly testing for the HPV virus. The only time we would care if that person had the HPV virus is if they already had some abnormal cervical cells. So we do what we call a reflex test. And so it's going to look for abnormal cells. If we're all good, we won't be testing for HPV. If there are abnormal cells, it's going to go ahead and test for the 13 strains of the high-risk HPV virus. Now, for women over the age of 30 up until age 65, we'll be screening every 5 years in immunocompetent patients, every 5 years, both with a Pap test and the HPV test together. And we'll be looking for, again, only the high-risk strains. We're not screening for low-risk strains of the HPV virus. For men, there's no screening that can be done. It's just purely on if they have warts, and they do carry the high-risk strains and to their female or male partners. So if you have a high-risk strain of HPV and it's causing changes to the cervix, what are your first steps? The first step is just to watch and wait. For the most part, We take a closer look with a colposcope to make sure those cells are kind of low-ish grade cells, or lowish grade changes to those cells. If there's high grade changes to those cells, we might choose to do a treatment where we remove the cells. And that can be done using cryotherapy or a LEAP procedure. And a LEAP procedure, you'll see on the left here, is an electrosurgical procedure where it just removes a very thin layer of the cervix and the abnormal cells along with it. Oftentimes people return back to normal PAPs afterwards. And then cryosurgery is just like freezing off a wart on your finger, but we're doing it on the cervix with a special shaped tool there. Now, if you have warts, what we would do is use cryotherapy, or a patient at home can use a topical treatment like imiquimod or podophylax and treat those themselves at home. But for the most part, a lot of these things is just focusing on a really healthy lifestyle and a healthy immune system. So avoiding cigarette smoke, we know that you clear the HPV virus a lot slower if you're a smoker. Really good sleep is important, healthy diet, all of those things. So, oh yeah, stress. No, stress is not good for the immune system. Okay, so our last infection that we're going to talk about today is the herpes virus. We're going to talk about herpes type 1 and type 2. So I feel like this virus causes a lot of anxiety for people, and a lot of concern and questions about testing and what can they do about it. So you'll probably hear some questions over the time, even as while you're working as a SANE nurse, even about possible risks of transmission. So HSV-2 there's the prevalence of about 16% in the total U.S. population. Significantly higher rates amongst Black women, 48%, which is really, really rather high. HSV infections are concerning, especially during outbreaks, because it's not only painful, but it does increase the transmission risk of other sexually transmitted infections, gonorrhea, chlamydia, and HIV. And then, when we kind of talk about HSV-1 and HSV-2, like what's the difference between those two? So HSV-1 historically has been thought of to just be an oral infection, so getting those oral herpes lesions. But we're seeing a much higher rates in genital infections now with HSV-1. Typically, it's a much milder first outbreak, and oftentimes we don't see the reoccurrence as frequently. HSV-2 typically has a much more it's more severe outbreak that you have, and you do see more frequent reoccurrences of it. But no one strain is only in one area of the body, oral or anal, genital. And it is transmitted via just contact with the herpes sore, saliva, or genital or genital secretions if folks have an infection in the area. It can be contracted via contact even when the patient doesn't have a visible sore. So we call that viral shedding, meaning the virus is living on that nerve cell and it kind of crawls on up to the surface of the skin. It sheds, a viral shedding, but there are no sores. And that does increase, there is an increased risk during that time period. Unfortunately, most people don't know when they're having it, so that can be a time of transmission. And you can get it if you've received oral sex from a sex partner who has oral herpes. So that might be when we're talking about that herpes genotype 1 in the genital region. Sometimes, people don't have any symptoms at all. They may never have an outbreak. They may have come in contact with it, and their body will never have an outbreak. If they do have an outbreak, it will kind of start out as a small group of vesicles, fever blisters. It opens up into a lesion, can sometimes be seen as fissures in a like kind of an atypical outbreak. And as I mentioned, kind of the herpes type 2 will often have a systemic symptoms, so fatigue, lymph node swelling, especially with that initial outbreak. Repeat outbreaks afterwards, not so much. But everybody says, boy, they are painful. So a lot of questions about testing, and I think it's important to be able to have this conversation with people about how we test for herpes. So the gold standard is always going to be a culture, meaning the lesion is there and we take a culture of the lesion. If the vesicle is present, while it still has that kind of fluid-filled vesicle, you're going to have to kind of pop open that vesicle because we need the fluid from inside. If it's an older lesion that's been healing and it has kind of a healed top to it, unfortunately you have to unroof that lesion to get a good sample. If you take a sample with it still as a vesicle or with it a roofed lesion, you're not going to get a very good sample and your results are not going to be very sensitive. The earlier the better during the outbreak. But the biggest thing is you got to unroof that lesion, and people are not going to love you for it because it's really uncomfortable. So that is really the true way you know what is going on with that lesion. Does that person have herpes? A lot of people ask for, I just want to be tested for everything. So I want to get my gonorrhea, chlamydia, HIV test, and I want a herpes test. Well, that's kind of challenging. So if we test the blood, we're finding out if somebody has an antibody to the virus. So Aunt Hilda could have given you a kiss on the cheek when you were a little one and your body came in contact with her herpes lesion, and you may test positive for type 1 herpes now. You've never had an outbreak yourself. You may never have an outbreak, but you have antibodies in your blood. So people who have never had an outbreak of any lesions, it's probably not the best test to be using as a screening test. It causes a lot of concern, and it's, it needs quite a bit of follow-up counseling, because what do you tell your future sexual partners, especially if you've never had an outbreak before? It's definitely a conversation to be had before just doing that blood testing. Now, there are certain times when it is helpful. So specifically if you've got a discordant couple, so one person has had outbreaks, knows they have herpes, the other person does not, and we want to see if there's any transmission that occurs during that partnership. That would be a reasonable time to do it. During pregnancy, of course, because there's risk of transmission to the baby and can cause for a need for a C-section if there's an outbreak. Or if possibly the patient didn't have any medical care during their outbreak and wants to make sure that that outbreak, which sounded pretty suspicious, was indeed HSV, then we might want to go ahead and do that. Some people also have kind of atypical presentations, like I was saying, like little fissures or something. That also might be a reasonable time to do that that blood testing if there's no current outbreak or symptoms at the time, but they have in the past. So it's just not recommended to be using that as a screening test, but it exists, and it's, of course, everyone's right to kind of know what their options are and to choose that for themselves. But I think it should come with a fair amount of education regarding what it truly means with the results, rather than just going ahead to do them. So culture first, always, with open lesions. So a person does have an outbreak. We know it's the herpes virus, and we want to offer them some treatment to go ahead and get those symptoms gone much faster. And we can offer them a few different treatment regimens, the acyclovir or Valtrex. For your first episode, like I was saying before, it's a little bit more uncomfortable for folks and can be more severe. So we do a longer treatment, and then reoccurrent infections typically get about 5-day treatments. And then the best thing to do is prevention. So educating on healthy lifestyle, keeping stress levels low, getting good sleep, having good nutrition. And if people just persistently are having outbreaks, there is suppressive therapy that can be used, and that's also often used during pregnancy too, if we know somebody has had HSV outbreaks frequently. So there is medication to make it a whole lot more comfortable, but it is a lifelong infection that people do have. There is no true treatment for it. And this is not a reportable infection. All right. So we came to the end. It's been about an hour of sexually transmitted infections. I know that it's just really super fun, but all really good information to know, and hopefully you picked out a few pearls to take along into your practice as a SANE nurse and as a nurse, just working in the community. So here are some additional resources. There will be a sheet for you guys to print out if you want these things. Know your community, know your pharmacy, know your clinic setting, what kind of testing do you guys offer there, so that you know, I mean, it makes a difference in the timing possibly of when you're doing those tests, the sensitivity and whatnot. So just know what's accessible for people. And then know your closest healthcare centers. So if you're working as a SANE nurse and you are recommending follow-up treatment, give people some options. I always recommend tomorrow morning, I want you guys to give that health center a call and make an appointment for your follow-up, because the sooner you can is better that you get on the books. And more information, the better to hand off to that primary care provider that they might be seeing, because they might not be up to date with screenings and testings for HIV. So, all right. Well, here are some references. I really thank you so much for listening to this and just getting more information for you and your patients. And really, I just thank you so much for the work that you do as SANE nurses in your communities. We are all working in different areas. We run up against all kinds of different issues. And I just thank you for the work that you do. You make a real difference. So please feel free to contact me with any questions. Again, I am not an expert at this. So if something didn't sound right, or you want to kind of update me on some things, I'm always open to hearing more information. So definitely let us know so we can pass it on and share it. But again, thank you so much for your work. And there is going to be a quiz at the end just so you can get some CME credit. That would be awesome if you want to go ahead and do that. All right, thank you again.